General practice, AI is the buzzword, and in this episode I'm joined by the team from TPP and some extra guests as well, as we talk about the variety of tools that SystmOne have been looking at to develop to help you in practice with AI and other tools as well, as we continue to tech enhance your primary care and learning. Hello, GP learners, and welcome to this episode where we're joined again by the team from TPP as we are looking at how AI can help you in general practice with the TPP tools that we've got. I hope you're all ready for this amazing episode. We did something similar a couple of weeks ago. We went through the pathology auto reviews and some extra sneak peeks. We broke 300 live viewers of that one. We're already at 200 plus as it is for this one as well. So this is going to be an absolutely amazing episode. I'm going to let the team introduce themselves. I'm going to go first to the team from TPP. Want to say hi to the EHP learners out there?
Yeah, hi everybody. Good afternoon. Yeah, my name is Dr. Chris Bates. I'm the Director of Research and Analytics here at TPP, and I'm joined by colleagues who coming soon into the session with Dr. Matt Curtis, who's our GP advisor here, and Simon Rowley, who's one of our product specialists, who will be taking you through some demonstrations, some functionality, and covering some of the key clinical questions.
Awesome. And a little bit later on, he's going to be joining us back in. We've got Dr. Shankar Vijay, who's a long-time colleague of mine. And weirdly, we realized it's the first time he's actually joining the live stream. How are you doing there, Shankar?
Yeah, I'm doing great. I'm a GP. I'm in Northwest London, and I also have a sort of digital lead role across London too. So great to be joining today, Candy.
Yeah, and we're hopefully going to have some extra people joining in and out, as Chris mentioned, throughout the live stream. But we've got various different things that we are absolutely going to cover throughout this live stream. In particular, we're looking at the AI solutions that TPP have developed to help for those of you out there in general practice and potentially wider as well. So I'm going to pass over to Chris to get us started as we start talking about these various AI solutions and stuff. Take it away, Chris.
Great, thank you. So yeah, everyone. Yeah, so as I said, good afternoon. So I'm Chris Bates. I'm a data scientist here and a software developer, but my background is actually in academic mathematics. I've been working in the digital health space, TPP, for over 20 years now, coming up to 20 years now. And a lot of the work that we do is really engaging with, it's around secondary use of data. So it's engaging with organisations like NHS England, with UK Health Security Agency, but also with things like born in Bradford, Biobank, and we were co-founders of the Open Safety Project with the University of Oxford. And it's really around how we use data for secondary use purposes to deliver better tools for use in general practice. So what I was going to do is just take you through for 10 minutes some of the common questions we get from a technical aspect around AI, and then Matt and Simon will come in and talk more around those clinical aspects and show you a demonstration of those tools. So just going to take you through some of those questions. And the first question we will often get asked is, where is the data processed? And it's an absolutely vital question that we see in all aspects of data flows and DPIAs, but probably more in terms of when there's AI products on the market, because there's lots more sub-processors used. So it's a common question we get. And I just want to reassure everyone, from our point of view, that's very, very simple for TPP. And the slide I've put up just now is analytics architecture overview of just a high-level overview of how the TPP services operate. And you can see there inside the dotted line in the light blue cloud, that's the services we run inside of those private cloud-hosted NHS-accredited data centres. And all of the data, when we're doing this, the major analytics work we do, and certainly the AI and machine learning data work we do, all of that stays within that environment. So we're not exposing anything to any external services or like other things. So that's a common question we get, and hopefully is reassuring. So the answer is all of it's processed within that TPP environment. Linked, a question we'll often get is, are we using any external services? Of course, when any of us are talking and thinking about AI at the moment in our day-to-day lives, conversations around AWS and OpenAI and ChatGPT are at the forefront of that. But that's also the case in a lot of clinical AI products. So are we using things like that? And these are the examples of, these are reference examples, but the kind of thing that we'd see in DPIAs that we were evaluating, where you can see that there's applications out there where data may be traveling to Azure, Microsoft Azure for OpenAI, or into AWS for the processing there. And that's where the AI capabilities are coming from. But from TPP's point of view, we've kept it, it's more simple. The data flows are more simple. So we put in The investment in that infrastructure that allows us to run all the mathematical sophistication and the complex algorithms we need to run machine learning tools and to execute them, we've built that inside our environment. So if, for people who are more technical out there, that enables us to run any algorithms in the Google TensorFlow software suite, for example, but without having to outsource that into AWS or OpenAI. It's all controlled within that environment. Related to that, and it's a really good question, and a question that we often get, is who's providing the compute power? Now, I think if you read the newspapers, you read journals, etc., what is crystal clear to everyone is that the compute power you need to run AI and run machine learning is very, very significant. So what happens is a lot of companies outsource that compute power. So they'll use services in the public cloud, such as AWS, such as OpenAI, as I've said, to provide that. Now, what we've done is, again, to simplify it, we've put the investment into providing that hardware and all that infrastructure. So that compute power is available freely at the TPP service, which means we can run these things without having to outsource. So again, keeping those data flows and that DPIA simple in the sense that everything is always stored within the environment that will be used, for the GPIT Futures framework, for example, everything stays within there. Next, we'll often get asked around generative AI and large language models. So, lots of people on here will know when we're talking about generative AI, this is a class of AI models which can create content. So in the clinical applications, it tends to be creating text and creating images, and they've got great applications. And the appetite for generative AI in healthcare is exceptionally broad. Everything from drug discovery to radiology workflows to automatic triage systems. But they do come with problems because, as I said, they are very broad and they are trying to do very, very general tasks. So we've seen, and I think really helpfully in the last few weeks, the Care Quality Commission have put out a new Mythbuster around AI in general practice. And some of the ones in there they highlight are the things that do use large language models. So these are tools like Heidi and Anima that are now becoming more common in general practice. So things like ambient voice technology, AI clinical documentation tools, and chatbots and generative AI. And there's no doubt that there's a lot of interest and a lot of potential for these tools to make a real impact on general practice. But they do come with, feedback we get is they do come with concerns. Some of those are around, some really high-level examples at the moment. This is an example from a few weeks ago, where an AI tool has potentially generated, because it's generating those diagnoses, it put false diagnoses on a patient record, which has meant they've been wrongly invited to a diabetic screening appointment. And that's led to, an NHS England safety warning in recent weeks that said these tools shouldn't be used to automatically put diagnoses on patient records. There needs to be human oversight. But from our point of view, this isn't what we're doing. We're not using generative AI. We're not using large language models at all. We're involved in a different class of AI models, again here, nicely described by the CQC, and ours is around predictive modeling. So you can see here that the predictive modeling angle the CQC have taken is to predict what patients might miss appointments and to help schedule those appointments in a more efficient way. Can we forecast the levels of staffing needed and assist with staff rotoring? Again, operational performance by using machine learning and AI. And can we use it to assess patient risks, such as predicting a risk of certain cancers? And actually, in terms of what we're about to show today and then some of the future work we've got going on, that very, very nicely describes what we're going to do. And the thing you can see there, and this is what we're doing, is it's a very well-defined task. It's a really specific task that we're training a model to do. It's not a broad, general thing like an LLM. It's specific. And the other thing that's important about that is it allows us to control it. When we're talking about generative AI and LLMs, what we'll often think about is, in the AI world, is that they're dynamic, they can change, they're learning all the time. But with these models, we can control them. We're just predicting that specific task. So we're not using generative AI, just doing it for that predictive modeling. What then comes along is how are these types of predictive algorithms developed? And as most people will know on the webinar today, there's a long history of predictive algorithms in clinical care. That goes back to the Charlton Index to predict 1 in 10 year mortality. A long time ago, through to ChadFast and then to QRisk. Long have we tried to put predictive algorithms into practice. And then that's become more advanced and more sophisticated, which I'll go on to touch on some examples of that shortly. What they have in common, these algorithms, they've all been developed on research level structured data, on defined cohorts, in ethically approved research databases. So those kind of databases, I'm sure people know of, are things like CPRD, the Clinical Practice Research Data Link, things like QRisk in Wales, things like SAIL, and our own database, ResearchOne, that we established back in 2013 in partnership with the University of Leeds. So it's anonymized data from general practice, but the model for all of those databases is that practices opt in and decide that they want that anonymized data to be included in the research databases, with the opportunity for patients to opt out of their data being used in research. So that might be a type 1 opt-out, and maybe the type 2 opt-out, historically, or now the national data opt-out, or indeed specific opt-out flags for research databases. And that's a condition of approval by National Research Ethics Services for these databases. When the algorithms are then being developed, they're being driven by clinical literature and clinical practice. So, rather than what historically people may have said is a fishing trip in kind of data analytics circles, if you're just looking for anything at random, that's not the case at all. They're driven by clinical practice and clinical indication, but trying to use the complexity of the mathematics to create very powerful predictive risk tools based on those risk factors. And they're validated. It tends to be, lots of the work is internally validated, so that's taking a test and a training set inside one of those databases and getting the metrics we need to know, so we know about discrimination, sensitivity, specificity, the kind of metrics that are used throughout statistical analysis like that. Sometimes there's the opportunity for external validation by using a combination of those databases, although in the UK, certainly in England, I think that's slightly trickier in the sense that there's so much movement for GP to GP that the data in these databases has quite a lot of overlap anyway. I thought an example of our own work here would be, it's very analogous to how the AI work has developed, and it's the electronic frailty index. So this is work that we started back in 2016. And the idea was, can we use the data that's routinely held in GP records and then incorporated into the ResearchOne database to predict the frailest people in the practice population based on clinical data and based on the research level outputs for a clinical frailty model? But can we do that back in routinely collected data? And the answer was yes, we could. And then we could embed that pretty quickly back into GP systems. So that if GPs chose to use that, if they chose to use the screen where they can see the frailty levels of their practice population, they could use that to inform clinical practice and use that to determine which patients were suitable for further assessment, for example. And the impact for the practices that used that was fairly stark, really. So this is in the first 12 months of the implementation. 2.5 million people were assessed for frailty. 1 million were then clinically identified as living with moderate or severe frailty. And you can see that then prevented 2,300 estimated falls and a big cost saving to the service. So it made an economic impact, but an impact on care. And that's what we're trying to achieve here. What we've then gone on to do is to look at how we can use more advanced models and more advanced machine learning techniques to produce more powerful predictive models effectively. And part of this is driven by national strategic directions for AI. You can see down the right-hand side there, all the major agencies in the country that are involved in research and innovation in healthcare, from NHSE to the NIHR, the Academy of Medical Sciences to HDR UK. And everyone's got a component of their research strategies around AI. They might be very broad, but in the context of what we're talking about today, it really boils down to, can we produce better predictive risk models based on that data, but using more advanced statistics and more advanced machine learning? So examples are, we've moved from the Charlton Index to the Cambridge Multimorbidity Scores, which are just more complex mathematics. The University of Leeds down the road here, they're doing some fantastic work with atrial fibrillation and using machine learning to come up with a predictive tool for finding undiagnosed atrial fibrillation in the community. The team at Nottingham have used those tools to produce cardiovascular disease risk scores, which are more powerful than the QRisk scores, by using these new mathematical techniques. And our own work here around predicting DNA rates that we're going to see today in general practice, and also providing cancer decision support, has been to use the same approach and the same targeted ideas of prediction, but to use more powerful tools to be able to do that. So can we tease out more information using new mathematics, which means we can do a better job of predicting. So I've just added to that, in terms of that, we're performing the same task here as conventional clinical prediction risk algorithms. who is most at risk, when is an event likely to happen. We're using the same structured data to do that, but we're using more advanced tools, still within that TPP environment, to be able to execute that. We get a question, has there been any clinical input from GPs? And I think this is a two-dimensional question, really, or the answer certainly is. And the first part of that clinical input has been yes. Actually, the types of the developments we've been doing have come from from GPs. So for cancer decision support, that came from GPs we work with who said, look, there's some tumour sites here that we could really do with support. It will really help to have clinical decision support and help with case finding, certainly for some rarer conditions. And if we could build that into the system, we'd find that exceptionally useful. So it was driven from that clinical use case, the sort of first suite of things we decided to work on. Similarly, with the DNA work, there's practices out there who have a lot of frustration about the percentage of appointments that are missed. It's frustrating for staff, it's frustrating for patients, and ultimately it's very expensive to the service. So the question was, could we predict who was going to do that so we can look at mitigating against that, either, for example, by phone calls, and Matt will talk about this later, or more SMS messages, or even overbooking clinics. We're not prescriptive about that. We're just trying to put tools in people's hands to do that. So there has been input from GPs in terms of what we decided to do effectively. But possibly more importantly, GPs have been heavily involved in real world evidence phases. So it's fine to go away and do this analysis on research level data, but how do we get those into practice? How do we look at, how is that implemented? And how does it perform in the real world? So just as examples of that, excuse me, with some of these cancer prediction tools, we worked with GPs, and specifically with GPs with a special interest, often working for charities who are dedicated to those specific cancers, on that real world phase. So sitting in front of the algorithm, giving us feedback on implementation, giving us feedback on how accurate it was being, so we could change the way we did that. And interestingly, the use of patient insights as a kind of overview screen of that, as opposed to just doing pop-ups inside of a consultation, came out of that real world evidence phase. That would be, a better way of doing it for certain cancers than it would be to interrupt workflow in a consultation. So it's massively important that we do that. And then finally from me, kind of what is the expected use of the algorithms? And I showed that example earlier around where, there's problematic things if algorithms are being used to actually put diagnostic, to automatically put codes on records or to automatically make clinical decisions. And that, that is certainly not how we envisage these tools being used within SystmOne. So our approach is that they're augmenting clinical and operational practice, they're providing that support, and they're doing that as a co-pilot. So it aligns with, the NHS England view that there should always be human oversight. These tools can be very, very useful to support care, but there should never be anything automated that's going onto the record to do that. So it's all around having a right-hand, sort of tool there at the right-hand side, which is helping you to do clinical practice and to operate more efficiently rather than doing anything specific. So hopefully I've covered off a range of those common technical questions that we often get. Matt and Simon are going to come in now and talk about and showcase some of those tools, but Matt will also cover off some of the more clinical questions we get around those things. So hopefully it will cover the broad range of questions out there, and then we'll have time to discuss those later on. So I'm going to disappear to the left. Matt and Simon are going to come in here, and I'll reappear on another screen. So thank you very much.
Thanks for that, Chris. Seamless transition there. Just wait for my colleague Matt, and we'll go through the demonstration of the functionality that we currently have in the system.
So artificial intelligence.
Just before we do that, if that's all right, Matt, I just wanted to make a couple of mentions. So firstly, we are over 450 live people, which is the highest we've ever had on the YouTube channel. So I just wanted to comment on that. We have had a few questions as well. More than happy people to keep asking questions. I think we're going to come to those once we finish the session that Matt and Simon are going to do. So don't worry, feel free to stick your questions in the chat. I can even see some people are answering the questions as well, which is really helpful. But we'll come to those in a second. So don't worry, we will get to your questions. I'm going to pass back over to the TPP team, and we're going to crack on from there.
Thanks, Gandhi. So yeah, artificial intelligence, it's increasingly part of our personal lives and professional lives. Most of us are using it either knowingly or occasionally unknowingly. And like all technological tools, it provides great opportunities, but with those opportunities come challenges and risks. And what we're hoping to do, and what we will do in today's webinar, is showcase some of the AI tools that are already available within SystmOne, as well as giving you a glimpse of what's coming in the not too distant future. So I'll hand over to Simon. Briefly, the three tools that we're going to be covering are patient insights, DNA probability report, and clinical assistance. And we'll
There you go. Excellent. Thanks for that. Yeah. Let's start with DNA probability report. So this is available in the system now. Some of you might be familiar with the DNA report. So you'll find this within the reporting menu and then appointments. So the DNA report is showing patients over a period of time that have already had a DNA. So it's, you might say it's reactive. You could then send an SMS reminder or a message once the events happened. But I think it was last year, there's about 8 million appointments that were wasted, obviously costing the NHS money. So there's been an appetite for a proactive approach to this problem, ultimately easing the pressure for everyone involved in that process. Particularly with the NHS 10-year plan, this is going to support allowing patients instant access to appointments and help. Massive benefits in proactive planning, missed appointments, and hopefully obviously increase overall attendance. So it is a tool to predict the likelihood of a patient not attending their next booked appointment. But what is it not?
So let's be clear, the DNA probability report is not a crystal ball. It's not going to tell you definitely if that patient will or won't attend their appointment, but it will give you an estimate. And maybe a good way to approach it is for those of you familiar with the Q-risk calculator, and that gives you a percentage estimate of something happening within the next so many periods of time. And the DNA probability does the same thing. It will suggest that this patient, and it will suggest accurately that this patient has a 20% chance of not coming for their appointment in the next week. It's not been designed as a tool to name and shame patients. It's been designed to help practices identify those patients who are struggling, either struggling with the times and dates and locations of appointments, or there may be other things happening in that person's life that require extra support from the practice. And as Chris said earlier, all of this is calculated within the SystmOne perimeter. The data doesn't leave SystmOne, and the data is processed entirely by SystmOne.
Cool. So let's go into the demonstration. So you can find this now within SystmOne. You'll find it by going up to the reporting menu there, down to appointment reports, and then to DNA probability report. And when you select that, you'll be presented with this screen. So towards the top, you can see the relevant filters. So I can report an appointment that patients have within a certain date range. I can show the top number of appointments. So I've selected 200 here. And I'll come back to the bulk actions that you can see, but you can utilize all of those bulk actions within that report. Once I've clicked Run Report just towards the top, you'll be presented with your top 200 patients that are most likely to DNA their next appointment. So you can also see the name, you see the appointment date and time, and also the percentage DNA risk. So over towards the right-hand side, that percentage kind of translates into the coloured spheres that we can see there. And I've just kind of showed you what those are with the tooltip. So you've got high, medium, and then low risk percentage-wise. From there, what you can of course do is utilize all of the bulk actions to be able to SMS the patients, perhaps send them an additional SMS reminder in addition to the reminders that you're already presenting to the patients through the system as well.
Thank you, Sam. So the nature of general practice in the UK has changed quite considerably in recent years. There are many, many patients who ask for and receive care on the same day, and they tend to be for acute, often self-limiting conditions. What this tool has shown is that increasing numbers of patients are requiring long-term care, they're requiring proactive care, And it's these future booked appointments that are often the ones that are more likely to be missed. And those are appointments that are not necessarily urgent, but are very, very important. They're the ones that have got impact for the patient's long-term health, things like vaccinations, things like screening appointments. So these are the ones, I guess you could say, that are easiest to miss, but most important to keep. And we've got examples of practices using the DNA probability tool to identify those patients, and then sometimes having a low-level light intervention, just an extra message to remind the patient about that appointment, contacting the patient a short time beforehand to find out if they still want that appointment and rebooking it if needs be, through to higher level interventions, such as talking about transport help that the patient may need to enable them to come to the appointment, and also recognizing that patients don't set out to deliberately miss appointments. There are reasons this happens. And those patients may benefit from extra care from the practice, such as that provided by social prescribers and health coaches. So there's all sorts of things that, as Chris said earlier, a practice can use these tools for to improve the safety and the quality of care that their patients get.
So yeah, in summary, this report is available for you to use now. You can utilize the tools already built into the system to send perhaps extra reminders. We've actually seen that improve clinic attendance by 30%.
30%.
Okay, let's go on to the next exciting tool that we have in the system. So this is called Patient Insights. Well, Patient Insights is a risk stratification tool, which for potential undiagnosed diseases across a patient population. Again, kind of reference into the 10-year plan, in this pre-radical shifts, focusing on prevention, not sickness, community, not hospital, and analog, not digital. So this ticks all of those boxes with using this particular tool. Also doing this enables helping the neighbourhood teams deliver on their processes as well. So what is it? I'll go through kind of the demonstration and show you how to utilize that particular tool. Essentially, it's going to allow me to review the patient's records. I can mark them as checked once I've reviewed them, and then I can utilize the built-in functionality again. What is it not, Matt?
So the tool, it's a population health tool. So it's a list of patients who are an increased risk of certain diseases. So it's not a screening tool. This is not designed to replace the well-established national screening programs for diseases such as bowel cancer or breast cancer. This is a case-finding tool, so it helps augment the clinical judgment and other reporting processes that the practice has. It's important to note that the information generated by Patient Insights doesn't form part of the patient record, so it's not visible to patients, it's not visible to other caring organisations providing care to that patient. It doesn't leave the SystmOne record via things like GP Connect or Summary Care Record or GP to GP. And most importantly, because it's a population health list, it's not going to create any additional burden to the clinician during a consultation. As Chris said earlier, it's not something that will generate pop-ups and interfere with the consultation. As Chris said, it's built, it's been trained on research one level patients, so that there's approximately 7 million patient records. So the learning environment is one which is highly representative of the population looked after by United Kingdom General Practice. And as we said before, there's no large language models involved. The information doesn't leave the SystmOne environment. So should we see how it works?
Yeah, let's go for it. So you should be able to see on the screen now. So this is the, again, up to the reporting menu to access the Patient Insights report. And then down at the very bottom there, you'll see patient insights. So selecting that option will then take me to the patient insights screen. So it's just a bit of navigation around. Towards the top left, when we change the number of patients, which you can see there, I've currently got 10, I can hit the refresh button and that will just update the screen for me. There's also an about button, which I can click on and learn a bit more information about the tool. You'll see the different registers towards the top there. So we're currently on the bladder cancer, and then we'll talk about the data that we can actually see in a second. But I'm just going to change the amount of patients that are showing on the screen. You see that now instantly updates. So as well as the demographic information, if we go towards the right-hand side, you can notice the practice ranking and the national percentile. So
it's worth explaining this in a little bit more detail. These are features that were more late additions to the Patient Insights tool at the request and suggestion of our clinical users. Percentage and percentile sound the same. They both involve the number 100, but they are two different things. I'm sure our audience know what a percentage is, but a percentile is best described as something that helps you place that person in a rank or in a band compared to the larger population. So these two columns that you can see towards the right hand side, there's practice ranking. Very simply, that states that patient's position compared to the other people registered at that practice. We know that general practices are different. They come in different shapes, sizes, serving different populations. So being number one in practice A doesn't mean that you necessarily have the same risk as being number one in practice B. So that's why we provide the national percentile to help the practice gauge with a little bit more intelligence the significance of this list for their patient population. The way in which we have seen practices and larger organisations using this list is a population health tool to identify those patients who are worthy of a closer look, maybe a record review or inviting those patients to another appointment. It can be used as a safety netting tool to identify patients who should have had something done and it was the practice's intention to have something done, but for one reason or another, they have slipped through the net. I've even seen practices who have used this tool to improve their data quality by ensuring that diagnoses are added correctly so that patients don't miss out on future care activities. And perhaps now's a good time to bring in our colleague, Shankar, to tell us about his experience and his thoughts on the tool. So I'll hand over to the technical wizards who can do this for us.
Okay, well, I think I'll probably echo what you just said about safety netting and case finding. So, look, we can all be variable as GP practices. I'm a sessional GP working across a lot of practices, and we can miss things. When I look at patient insights, sometimes I find patients that actually we just have failed to code for whatever reason. They have a known diagnosis of cancer, but obviously coding them has really helped them make sure that they get reviewed. There's been cases where actually it is about that soft safety netting. Did they come into a consultation, get asked, maybe blood in the urine or something? Do they not return back a sample? It was handed over to the patient. So there have been some patients where it has activated could you just follow up this action we discussed? And there are some that you're not completely sure why they're there, or actually that you've just been too efficient, that you have actually acted on it. You have just referred them down that urgent suspected cancer pathway a couple of days ago, and you think, oh gosh, I should have just given it a couple of days before I checked the report. So it has been useful for all those reasons in that safety netting and also that case finding approach.
Awesome. Thanks, Shankar. If we just show you a couple more features of the Patient Insights tool. So you'll notice over on the right-hand side, if a patient appears on more than one of these registers, you're instantly informed of that just with a tooltip over on the right-hand side. So I can just hover over and see that information. You can also interact with the patients that appear on this list. So just right-clicking, we can then go into the patient's record, carry out our investigations, And then we can use this as a tool to be able to mark as checked or clear the checked, and also add notes. So what you can see here is the notes that are going to only appear on the patient insight screen. It's not going to appear anywhere within the patient's electronic medical record.
And the reason for providing this functionality is that particularly for larger organisations, there may be more than one person working from this list, or a person may come back to the list periodically. So it's important to keep track of what actions have been taken and what decisions still need to be made about that patient. And as Simon explained, the nature of these illnesses are that some of the features of, say, ovarian cancer may also be features of uterine cancer. So it's quite likely that a patient could appear in more than one of these lists. And the functionality, the flags to the right-hand side, help indicate the presence of that patient on other lists.
And as Schenker said, these notes would then be, you can see referral already sent, perhaps you might include that, so you know you've already dealt with those patients. And then you can retrieve the record and utilize SystmOne's great tools for searching the tab journal, for example, and being able to find the information nice and easily that you need. We also provide a history of those notes. So if you add a note and then subsequently change it, or someone else subsequently changes it, you'll be able to see all of that audit against that patient within the screen. And then finally, I mentioned this at the start, but of course you have access to all of those bulk actions. So being able to send messages, being able to create documentation, all of those bulk actions, as you'd expect, are available from the list of patients. Okay, shall we go on to the next one?
Yeah, Can I interrupt if that's all right? I'm just aware of the volume of questions we've had around the patient insight tool. It might be better if we take those now, just because there are quite a few. And I think it may confuse if we talk about this one and then the clinical insights as well. So if it's okay, I'd like to just go through a couple of those. Is that okay?
Certainly.
Yeah. I guess we've got a variety. One of the frequent ones, and I'm just trying to find similar. So CHCP is asking, and I think that also about some of the other tools. So are these GP tools or are these community-based tools as well?
That's a really good question. The current iteration of DNA probability predictor requires a GMS registration. It requires a little bit of a track record at that organisation. And I'm aware that a track record will exist in community modules, but also frequently community modules receive referrals and there isn't any previous registration. And what we've been looking at is a way of sharing that information with the from the GP to the community service. So, for instance, as part of the referral information that a GP sends to the community, the person's risk status could be shared. And that's entirely within the control of the sending organisation, but it's clearly helpful to identify patients who've got an extra challenge in being able to attend appointments. And likewise, that is also, we're looking at making the status available at the time of appointment booking as well. So the DNA probability predictor is something that is certainly growing and expanding, and it may well be available in other modules in the future, but not immediately.
Okay. And I guess we've got a question from James. He asks this also about the patient insight tool as well, but will the algorithms for like the DNA prediction be made public so practice can understand why patients are being identified? So I don't know if obviously the algorithms maybe, but I guess is there information available to the practice of clinicians as to why particular patients might be high risk for DNAs or why they might be high risk for those cancers in terms of assistive tools?
It's a great question, and I'll...
Yeah, I was just going to say, I've just been looking at all the questions that have been coming through, and thank you. There's some, really interesting, really good feedback. Currently, we don't expose the reasons, so if we think of DNA to start with, the reasons that the sort of factors that go into that prediction are things like when the appointment was booked, what time the appointment was, what's the distance, the length of time between the booking and the actual appointment, and then some base demographic factors, for example. And we don't expose those currently in the clinical system, and we've seen the same question around would it be possible to show the factors that inside the clinical system that have led to, a higher prediction for a cancer risk, for example? And interestingly, that's, I think it's a really interesting point. It's not something that came out of those real world evidence phases that we had, but we'll certainly take it away and talk about it. It's interesting, in the last few weeks, we've had the same question around frailty. So that's, a thing that's been used inside the system and well used in terms of that impact. But we then had the question saying, would it be possible, to be able to see the components of the patient's medical history that are contributing to that frailty score? So the answer currently is no, we don't, but I think it's really useful feedback, and we'll go away and discuss and then hopefully catch up in a later session.
Sure. I guess to emphasize that, so one of the other comments we have from Stephen Murdoch is tried selling to a number of practices, and they're finding it hard to use without the overview of why people are in the first place in the first place and stuff. I'm going to go to a quick comment just because I want it to clarify. So Stephen has asked, are these fake patients that you're demonstrating? I'm aware that TPP have a massive amount of test dummy patients. Absolutely. I mean, you guys can confirm it, but yes, these are test patients, not real patients that you're demonstrating.
Yeah. But a good question, Robertson. Thank you very much. And it's nice to see you watching.
Perfect. Last one I'm going to take on this section, and then we'll go to the clinical assistant. So are these patient insights visible within the individual patient record, say as an alert? But I know this is also a question of concern I've had from other clinicians, as can the patient see this, and where I guess is also, if they could, the risk/liability, because I guess what some people are worried about is if a patient finds out, oh, you have higher risk for cancer and nothing was done about it, where does that sit?
Yeah, so good question. And as we explained earlier, that this information in patient insights doesn't form part of the patient record. Same with clinical assistance. It doesn't appear in the patient-facing services. It doesn't leave the practice by GP to GP or summary care record or other data flows. It wouldn't form part of a subject's access request.
And I think, just to do, I sound like a broken record, but just to draw the analogy with frailty, for example, those frailty scores appear on a screen, but they are not available inside the patient record. If there's then been, as a clinician, you've looked at those and acted on them and maybe done that assessment and then coded someone, with the SNOMED codes that were authored in terms of moderate frailty or severe frailty, and you've made that clinical decision, and that forms part of the record, then as long as you're not marking that as private, that would be available to the patient. So it's the outputs following the support from the tool that could be available, but not the actual tool itself. And I think the other part of Ed's question, which is it possible for opportunistic things, is, thanks Ed, that's a beautiful segue into the next section around the clinical assistant.
Definitely. Actually, just before we go, I'm just going to ask one tiny one. It's a clarification one. So you mentioned about the patient being number one at 0.01 percentile. Can you just clarify that again, that Max? I guess there's been some confusion as to what I'm assuming that means that 0.01 percentile at the end, so the most likely out of the population. That's my understanding.
We've just been talking about it. I think our thought with this one is a really good question. We need to do a better job of explaining it. Is we'll go and refresh the FAQs and then send them around to everyone. We'll put some examples in and make it more clearer as to what those percentiles mean, so that people can digest them in their own time.
Okie dokie. Anyway, we're going to segue back into clinical assistant, because I know many people are keen to know about this. So let's bring that back on for you guys, and
thank you.
Take it away.
Okay, so this next part is we're going to go through clinical assistant. So the clinical assistant runs in the background during a consultation, whilst you have the record retrieved of the patient, and it's designed to aid decision support at the point of care. So we've seen kind of patient insights. This is now giving that advice and support at the point of care. We'll go through, as part of this demonstration, some of the controls that are in the system. So it's actually governed by organisation preferences and user preferences. And we'll see how that actually shows to the clinician as well. We've put those controls in place to recognise that clinicians have different ways of working. And I'll go through those as part of the demonstration. So essentially, it's going to be a prompt during a consultation, very similar to kind of the information I'm getting from patient insights.
Yeah.
So,
and it's driven by the same artificial intelligence that provides the patient insights list. So it's the same data processing. When we were describing patient insights, we were at pains to point out that that was a population health tool. It doesn't interfere with the doctor-patient interaction. There are no pop-ups, but we recognise, and again from feedback from our users, we recognise the benefit of that opportunistic intervention, which Ed alluded to in his question. So clinical assistant can be seen as the in-consultation partner to the patient insights tool.
So on the screen now you can see we're in a patient record. So again, it's not a real patient. And I'm going to carry out a simple consultation for demonstration purposes. So we've entered in the history, we've noticed blood in stool, and we've actually coded that as well. But we've also got free text information within the examination.
And for the benefit of the clinicians watching, this is a simple example. Most clinicians would recognise that these are symptoms that are probably going to prompt you to do something anyway, whether you've got a computer assistant or not. But it serves to illustrate the functionality and how it can be then beneficial in those more subtle presentations.
Yeah. And then once clicking save or pressing keyboard shortcut, we can then be presented with the information. So over on the right hand side, you can notice the banner. So that's kind of always there for me. But you'll notice we can get a little pop-up to pop out to show me information that I've entered. And now potentially there we need to consider the bowel cancer for this particular patient. You'll also notice on the patient home, we have the alert that's kind of always going to show there. So this can be useful if it's been triggered now at this point. I can then also trigger and show for further clinicians to go into the patient's record. Just to point out again and to reiterate, this isn't going into the electronic medical record. It's not going into the tab journal. It's there as a prompt for users that have been given access to be able to utilize this tool.
So the key message that we want our users to be getting, that this isn't a replacement for clinical judgment. This isn't making a diagnosis. This is there to give the user a nudge in the right direction. And that nudge can be acted on, or that nudge can be ignored. It's entirely down to the clinician to make that judgment.
So in terms of preferences, you'll notice there is a clinical assistant preference, and this is where, before, you can allow, as a system administrator, clinicians or users to be able to actually use the clinical assistant tools. You can allow all staff members to do that as a blanket at the top, or you can be selective over patients.
And certainly as a practice starts to use this tool, they will, I'm sure, want to roll this out cautiously with a few experienced and enthusiastic users before then making it available to the wider clinical workforce. So the organisation preferences box, which I'm sure you're familiar with from other bits of SystmOne, enables you to switch it on for staff in an iterative way.
There's a couple of preferences you can do organisationally and also as a user. So I mentioned about kind of pop-up fatigue. You might not want the pop-up to show. That can all be controlled either by the organisation or the individual. So there's a column there for auto pop-up that will show you, as it showed on my screen from before, it'll pop out that little banner for you. And user preference wise, there's the option to update on patient save. So that's what happened in my circumstance before. Well, there is an option to say don't update. So this will allow later on, so next time someone with those access rights that we said before, they will get the pop-up when they retrieve the record.
So it's important to emphasise that this is functionality that's controlled by the user, whereas the previous screens were the organisation preferences. So that's set for the practice as a whole. My usage of this is such that I would very much welcome the homepage with a alert on the patient homepage to tell me that this person is on the bowel cancer list. That will enable me to approach that consultation slightly differently, perhaps asking a slightly different pattern of questions, having a lower threshold for action based on that pre-consultation warning. It's not going to change completely what I do. It's just going to make me think about the consultation slightly differently. Of course, once I move away from the home page, that warning is no longer visible to me, but down the right-hand side, the panel at the far right-hand of the screen provides a reminder about not just the appearance on a list, but also the number. And then by pressing the icon, I can then get more functionality, which is configurable by the practice. So quick actions and all that sort of stuff can be set by the practice.
And then there is some customization that can be put into the system as well. So what we're seeing here is the clinical assistant quick action setup. So from there, it's within your workflow menu. You can actually set up the actions when you click on the action button, much like a patient status alert. You can click on the action, and then you can actually set up the actions that can be completed as part of that process. So lots of customizations to be able to complete those within the record.
So I'm conscious it's been a big subject for us to cover, and I'm conscious time is tight. As you'd expect with a product like this coming from SystmOne, we provide a full suite of documentation. Practices who are about to use these tools, I'm sure, will want to do a DCB 0160. We know that that's quite an arduous process, so we provide the hazard log, clinical safety case, DPIA, user guides, all of the stuff that you need to do that. As we described earlier in the presentation, SystmOne is a trusted provider of software to the NHS. We've been doing this for over a quarter of a century. The processing, the data all happens within the SystmOne perimeter, and we are Cyber Essentials Plus accredited, DSPT accredited, ISO 27001 accredited. The take-home message for this is that these are not replacements to clinical judgments. Doctors and nurses and healthcare practitioners will not be made redundant as a consequence of this. These are co-pilots to help you deliver safer, more effective care.
Now, just we mentioned about the clinical assistance that is coming soon and is going to pilot and development. Just wanted to touch on some other really exciting tools and features that we're currently working on and will be coming soon into the system. We've shown you the DNA probability report, and it's kind of outside of the record at the minute, but we're looking at putting that into the record and at various other touch points within the system where that's going to be useful. Could be patient status alerts on the patient home screen, as we see, and also when you're booking an appointment, and perhaps exporting that into a referral letter.
Exactly.
Also there you can see new AI models. So we've got the AI models that you've seen on the screens already, particularly kind of focusing around cancers, but we're very keen to include more AI models within there. So we're actually very open to your suggestions as well. So please get in touch if you have any particular ideas about the types of models that you'd like to see within the system.
Yeah, we're very fortunate to have such an engaged user base. Many of the tools that we've demonstrated have come from ideas from SystmOne users, and we know that there are many diseases, not just cancers, but other long-term conditions that would benefit from better prediction, earlier diagnosis. So if you've got your suggestions, then bring them to us.
Well, and then finally there, I'm really excited about this one, is the resource planning. So much like the sort of reactive DNA report, and then we've released the predictive DNA probability report, this is kind of enhancing the current appointment reports that we have in the system.
So SystmOne is already packed full of tools that enable you to report on things that have happened. You know how many appointments were done last week, how many prescriptions were issued last week, how many blood test results were processed, how many referrals were sent out. And knowing what has happened is really good. But imagine if you could use that data to predict what next week is going to be like, what next month is going to be like. Map that to your staffing levels, your holiday list, your sickness list, and you can then start to deliver a very, very safe service, and one that patients will be even more satisfied with.
So now that's kind of AI, and then other functionality that will be coming soon. I know there's a big one at the moment, which is document management. So in terms of document management improvements and updates we're putting into the system, we recognise it's a problem in terms of the time spent processing documents within general practice. It's a big topic that's being talked about.
So if we can get the human beings to do fewer clicks and let the practice staff be enabled to do higher level things, that's a win for everybody.
So what we're looking at doing is making it more streamlined, the process of processing documents more streamlined. That can be introducing new screens or new screen to make that easier and less clicky. Focusing on making the workflow generally just a whole lot slicker and faster, utilising OCR to be able to make those processes even quicker, and also a workflow engine for the next steps. So being able to customise those next step features, much like kind of other functionality in the system. Also, we have LibreOffice as well, so coming soon. So this is a free software that's available, but it kind of makes you see that you're not tied to a particular word processor within the system. We've made it very simple to be able to convert your documents, your current templates from word letter to Libre. You can utilise one or the other or both.
And this is particularly relevant in an era where the NHS has not got infinite cash. It needs to spend its money wisely, and being able to use software that's cheaper or even free is going to be advantageous in then enabling money to be spent on other things that are more beneficial to patients.
We've also working on some enhancements to System Connect, as always with that. Letters, documents being able to send and be downloaded. We're going to make more granular time capping categories, better intuitive URLs, and streamlining patient matching as well. Addition to that is improved questionnaire designer and also configurable quick action buttons when processing. So loads of interesting stuff with that. And then you'll also notice auto issue. So again, this is something that we're working on in terms of repeat requests that have been made by patients through online services, SystmOne. So this can be based on the patient and or the drug, and it's going to streamline that process when those requests come in.
So the way that we envisage that will look is that the patient makes a request for their regular medication, and if the practice has determined that patient is on an approved list and the medications are on an approved list, then the request will pass straight through to the prescription issue screen to be signed by the prescriber. It will, of course, obey the existing medication review rules in place by the practice, and of course, the number of medications and the number of patients remains entirely within the practice's control, but it avoids human beings having to do unnecessary mouse clicks.
And I think the final thing from us, just wanted to reiterate some of the recent releases that have gone into the system already. Visualizations, we've released a whole load of visualizations that you can utilize and just add to your clinical trees today. So these are being able to share information really clearly within the patient's record, includes things like graphs. If you haven't already, definitely encourage you to at least add them to your clinical trees and have a look at those. We've also done a lot of recent releases for Brigid. So this is being able to allow documentation to be added through Brigid into the patient's records. So that could be images or photos of documents. We've done a lot of releases around the appointments and visits functionality. So you can now mark an appointment as arrived or a visit as arrived when you get there, when you started it, when you finished as well. And there's also the ability to be able to book appointments and visits from Brigid.
And the addition of photos to the patient record, I think, is a particularly powerful tool because clinicians could have Brigid in use in their consulting room alongside the desktop SystmOne, and it's a neat way of getting documents and images onto the record.
Yeah, and also just coming soon with that, we're also going to be working on quick action templates launched from linked templates as well, so you can streamline that process of accessing multiple templates. Auto reviewing, you might have seen the previous webinars on auto reviewing as well. So that functionality, again, available within the system, and you can utilize auto reviewing now. So that finishes the presentation.
We've covered a huge amount of ground. Apologies that we've probably galloped through things.
Definitely. And there's been loads of comments about this. So I appreciate we're pretty much at what we said we were going to cover in terms of time, but I'm going to push us a bit further because there's so many questions coming through. So hopefully TPP team and Shanka can stick around just a little bit longer to go through some of these questions. I'm in the interest of time, I'm going to try and summarize some of them that came from earlier. So one of the earliest questions we had was from Pyrosard about compliance stuff, which I think, Matt, you mentioned about the fact that you've got all the relevant documentation and stuff. And I believe that's available either on the website if people ask for it. I can't remember which route it was.
Yeah, I mean, it's worth flagging up our policy for this kind of thing in general. So if you look on our SystmOne help, all of the documents that you will need are there, including the hazard log, including the core safety case, and then the additional safety case documentation. So it's not kept behind a paywall, it's not under lock and key. We make it visible to all of our users.
Perfect. We're going to rocket through these ones. So then Stefan also asked, is the clinical assistant already available?
It's currently being piloted by an increasingly large number of practices. So it's not available system-wide, but we're hoping that it will be there sooner rather than later.
Okie dokie. And then Emily asked, is there a training guide for clinical assistants so they can start potentially looking at using it when they have access to it?
So there will be, yeah, as any functionality that we release to the system, there will be training videos and training guides that support that. So as and when it's been released.
Sure. Gav Anthony, is the use of clinical assistant audited? If the clinical assistant prompts the user of a risk, does the user click an action button or not? I know this is a common thing that people have been asking about, and there's various other questions similar to this. But I guess also then is the liability question. If a clinician clicks no or doesn't do something, where does that sit, given that we now have a system that kind of suggests some complications for that patient?
So the subject of auditing people's record access, what keys they've pressed, is quite a complicated one, and that's probably going to be best answered by the user guide that we publish alongside clinical assistants, because it's a complicated question to answer.
Okay, but is it audited? I guess, is there a way to audit it either from the practice or from the TPP's perspective, I guess, because it didn't seem like there was from the way it came up, but I'm not sure.
In the pilot, there is the audit function isn't available to the users, but that will be one of the things that we'll be looking at when it's released across the system.
Okay. We then had a question from Claire Donnelly. I'd really like an AI tool that can scan the patient's free text and new journal letters and flags and misdiagnosis codes. Is this where clinical assistant's going to end up?
That's a really good question. I empathise with that request. I'm going to look at my technical colleague to answer that one.
Yes, really good question. Sorry to come past. In the future, that will be an interesting thing. I think it does walk us into generative AI, large language model space, which earlier on we were highlighting some of the existing concerns around deploying those tools. So I think it's a bit of a watch this space, to be honest, but totally understand the utility of that across a broad range of clinical areas.
Yeah, I think Shanka has great experience of working across the NHS, and he may have a very valid opinion about this as well.
Yeah, I can see why users are asking for this. And obviously, like you said, there's obviously pros and cons and risks and a lot of safety things that need to be thought through. Can I just say one quick comment to the audience about clinical assistant, because I'm piloting it. I just want to reassure that the first fear that we can have is alert fatigue. Will this pop up constantly and you'll be rushing to the preferences to switch it off? I've definitely not found that experience. This is not like typing fever in the whole sepsis type alert avalanche. And it's, I think the comments the audience said about, wanting to know why the patient's on the list definitely still applies. And it's great that TPP is looking at it. But it's a different experience when you're with that patient or you're in that patient record or having an encounter to when you're going for a patient insight report. So I look at it as the other side of the coin to patient insights, the sort of reactory thing when you're actually having an interaction with the patient.
Awesome. We have loads of questions around the document management aspect. So I guess the key one is timeframes. I know that this is still being looked at in terms of what functionality is going to be available. Any further detail, any timeframes you can give us? Because literally all the questions are, when are we going to find out about this one?
Hi. You haven't seen me before on this webinar, but my name's Ashley Brock. I'm one of the account team here at TPP. Obviously, we're keen to get it out as soon as possible. There's a small scale implementation around a select number of practices happening in the next couple of weeks, which will then be slowly extended to a wider cohort of practices with a view to releasing it as soon as we can. If I had to hazard a guess, it'd probably be around October that it's on general release to everyone, but obviously that's dependent on the feedback from the practices and the pilot sites. So thank you to everyone who's put themselves forward for participation in the pilot. We haven't had a chance to get back to everyone yet because obviously the number of interested parties is quite large. So if you haven't been spoken to as part of this initial phase, you may get spoken to as part of the extended rollout over the next few weeks. So we've got everyone's details. We know that you're keen to have it, and we're trying to get it out as soon as we can. And as things materialise throughout this next period, we'll obviously keep the user base informed through the various different channels, whether that's the system, whether that's Dr. Gandhi's channel, or whether that's through our mailing lists. Obviously, we're keen to share as much information about the exciting developments as we can.
Definitely. And if you want to see that come up, definitely let us know down below and stick it in the comments. I'd really appreciate it if you could do that. And if you have found this useful, definitely give it a like. I think for me, one of the key things people seem to still be asking is any idea what that document management flow might look like, those changes and stuff. And you mentioned about reducing the clicks and stuff. I guess people seem to be quite keen to know, I guess, where it's focusing on. Is it the OCR? Is it the ingestion? Is it something else? I know you guys have got plans for it and still working on it, but any further information we can have?
I think it's all of the above.
Okay.
We released some information around some of the general features around automatic matching, around the automatic coding, and then the triggering of specific workflows and automatic filing elements. So obviously streamlining and making that process as slick as possible is the intention. As soon as we've got videos around the functionality and some prototype screens that we can share to a wider audience, we'll do that. But obviously the additional products that we've seen on the market that kind of fit into this space, I think we're going to do a better job in a more seamlessly integrated fashion, obviously at zero cost to the practices. So I think we know what other things are in this space, and I think we're looking to beat those.
Awesome. And last question I'm going to say was from Emily. So you mentioned one of the other things coming soon is the Libra integration. I guess just clarifying, is this mainly about cost, or does it also give some feature changes as well, particularly something about editable documents and things?
Yeah, I mean, the Libra Office is a free open source platform, so there's no charge to it. But what we've done is fully integrated the Libra document functionality into the system. So there's no charge for that in terms of utilizing that additional functionality. We've made it really easy to be able to switch your current templates over to LibreOffice if you want to use those. So I guess in summary, it's a free word processor that you can use alongside SystmOne.
Yeah, I think we definitely see organisations who spend a lot of money on those licenses for Microsoft Office and particularly Word, and look, it's a real opportunity to do, at a time when budgets are exceptionally tight across general practice and the wider NHS, it's time to make a cost saving by taking a free product instead, which will give you all the functionality you need.
I can definitely see the ICBs keen to look at that current cost savings that hopefully will then be rolled back into general practice and services from there. Thank you guys for this. Thank you, Shankar, as well, for joining, giving your perspectives. I know I always value them as well. I know people are wanting more on the document management. Hopefully we will have some more details for you as soon as possible. If you do want to check out the other thing that they mentioned, which was the auto review, as we said, we did cover this a couple of weeks ago. The links to that are going to be coming up round about here. And as always, we'll be here to take and answer your primary care and learning. We'll catch you in the next episode.